Welcome to the Rad-On Smart Review GU Cancer series.
Glad to be here digging into this.
So I want you to imagine stepping into a boxing ring, right? And your opponent has this totally bizarre, almost counterintuitive weakness.
Okay, I'm picturing it.
He's the kind of fighter who can absorb like 1,000 quick stinging jabs right to the face without even flinching.
Just eats them.
Exactly. He just eats them and keeps moving forward. But if you plant your feet and hit him with one single heavy lumbering swing, he shatters. He just goes down instantly.
Oh, the classic glass jaw.
Right. That strange glass jaw opponent. That is prostate cancer.
That is a really fantastic way to frame it.
Yeah, I mean, usually when we talk about a medical diagnosis with patients, there's this immense expectation of like precision and clarity.
Like an engineering problem.
Totally.
Yeah.
Like break your arm, the x-ray shows that jagged white line across the radius, and the doctor just points to the screen and says, there it is. We cast it, it heals, we're done. It's very binary.
And patients really find comfort in that visible, categorized certainty. But in oncology, and particularly in genitourinary oncology, the reality is, well, it's far more complex.
And nowhere is it more complex than when you step into the world of prostate cancer radiation. The diagnostic and treatment landscape is incredibly murky.
Oh, absolutely.
When a patient sits across from me, I often feel like we're trying to navigate this massive ship through dense fog.
Right, because we know the destination, right? We want to cure the cancer and preserve his quality of life.
Exactly, but the exact route to get there is full of hidden hazards and competing maps from different decades of clinical trials, plus a lot of very strong, sometimes conflicting opinions among oncologists.
It is the absolute definition of clinical muddy waters. I mean, the sheer volume of data, the shifting paradigms, the evolution of the technology, it can overwhelm even really seasoned practitioners.
Which is why we're here today. Our goal is to cut through that fog and map the safe harbors for you.
Right. And in our previous discussions, we kind of built the architecture,
Yeah, we covered the intricate pelvic anatomy, the prognostic risk groups, the whole workup process.
And that often anxiety-inducing question of active surveillance. But now we are shifting our focus entirely.
Yeah, we're moving away from the workup phase. Today, we are diving headfirst into the actual physics, the radiobiology, and the clinical execution of treating the intact prostate.
Specifically with external beam radiation therapy, or EBRT.
And to do that effectively, we can't just look at the treatment guidelines in a vacuum.
No, you have to understand the historical evolution. You need to dissect the dose escalation trials that define the last 20 years.
And then contrast those with the modern rise of moderate hypofractionation.
Right, but we don't want this to just be a dry recitation of statistics. We have a lot of highly technical ground to cover.
So to keep us rooted in the real world, I want to introduce a specific patient. This is going to be our case anchor. We'll keep returning to his specific anatomy and anxieties throughout this entire discussion.
Okay, I have my pen ready. Walk me through his presentation.
All right, we have a 66-year-old man. He walks into your consultation room. He's been diagnosed with unfavorable intermediate risk prostate cancer.
Unfavorable intermediate. Okay. What are the specific parameters?
Let's look at them. His clinical T stage is T2B.
Meaning the doctor could feel a tumor involving more than half of one side of the prostate during a DRE.
Yep, the digital rectal exam.
Yeah.
And his prostate-specific antigen, his PSA blood test, is elevated at 14.
Okay, PSA of 14. And the biopsy pathology.
Grade group 3, which translates to a Gleason score of 4+3.
Right, so the primary pattern is the more aggressive pattern 4. And what was the core positivity?
He had a Gleason 4+3 and 8 out of his 12 biopsy cores.
Wow. Okay, so this isn't a microscopic incidental finding.
No, this is a solid, aggressive volume of disease.
Right. It absolutely demands definitive treatment. What does the advanced imaging show us?
We get a multiparametric MRI of the prostate. It clearly highlights a 2.1 centimeter PIR80 says 5 dominant intraprostatic lesion.
The DIL.
Exactly. We're going to refer to this as the DIL moving forward. This lesion is sitting right in the right peripheral zone of the prostate gland.
Okay, crucial detail there. Did the MRI show any extraprostatic extension?
No extraprostatic extension. The tumor hasn't broken through the prostate capsule, and there is no invasion into the seminal vesicles.
Good. Any systemic imaging?
Yeah, we ordered a PSMA PET scan, which, looks for that specific protein on the surface of prostate cancer cells.
And the results?
The PET scan shows intense, bright, local uptake exactly where that MRI lesion is. but absolutely no involved lymph nodes and no distant metastasis in the bones or organs.
Okay. That is a highly representative, classic presentation. I mean,
It,
this is the bread and butter of a modern genitourinary radiation clinic.
it really is. So he has localized but dangerous disease. He goes to a multidisciplinary tumor board. They review the imaging and pathology, and he is referred to radiation oncology for definitive external beam treatment.
Makes sense.
And when he finally sits down in the room with you, he looks just overwhelmed by all the brochures and Google searches he's done.
They always are. It's a lot to process.
Yeah. And he asks two very direct, pivotal questions. He says, Doc, exactly how much radiation dose do I actually need to cure this thing? And I read online about guys getting this done in just a few weeks. Can you cure me in fewer treatments so I don't have to drive here every day for 2 months?
Those are the exact right questions for him to ask.
Right. But to answer them accurately, and more importantly, safely, we need a deep, fundamental understanding of the underlying machinery of radiation.
We absolutely have to start with the radiobiologic foundation.
Let's do that. Because I always tell residents that the prostate is kind of the rebel of the oncology world.
It really is. It simply refuses to play by the normal, established rules of radiation biology that govern almost every other cancer we treat.
And understand why, we have to unpack a concept called the alpha-beta ratio.
Right. Because before we even touch a clinical trial, before we talk about survival curves or toxicity rates, you have to understand this core biologic principle.
The linear quadratic model. It's basically the mathematical backbone of radiation oncology, right? It models how cells die when exposed to ionizing radiation.
Exactly.
So let's translate that for you, the listener, because the math can get dense quickly. What does the alpha and the beta actually represent in a human cell?
Functionally, you can think of the radiation beam as causing two types of damage to the DNA of the cells.
Okay, two types.
The alpha component represents the direct, lethal, double-strand DNA breaks.
So one hit, the DNA shatters, and the cell is irreversibly doomed.
Precisely. It cannot repair that damage. Now, the beta component, on the other hand, represents sublethal damage.
Like single-strand breaks.
Yeah, single-strand breaks or minor damage. The cell actually has repair enzymes that can fix this beta damage over the course of a few hours.
But if a cell accumulates enough of these sublethal beta hits before it can repair them, they sort of compound into lethal damage, and the cell dies.
Exactly. So the alpha-beta ratio is just a way of describing the balance between those two types of cell death for a specific tissue.
And historically, the paradigm has been pretty straightforward. Most aggressive solid tumors, like a squamous cell carcinoma of the head and neck or a small cell lung cancer, they divide rapidly.
Very rapidly.
Because they're dividing so fast, they have a high alpha-beta ratio, typically in the range of 8 to 10 gray.
Which means they are heavily reliant on that direct alpha kill mechanism. As a result, these high alpha-beta tumors are relatively insensitive to changes in the fraction size.
Fraction size meaning the daily dose of radiation we give, right?
Right. If you give one big dose or several small doses, a high alpha-beta tumor generally responds similarly to the total overall dose.
But the critical limitation has always been the healthy, normal tissues that surround the tumor.
Always. The late-responding normal tissues, like the spinal cord, the brain, or in our case, the rectum and the bladder, they divide very slowly.
And slowly dividing tissues have a very low alpha-beta ratio, usually around 2 to 4 grays.
This is the fundamental crux of the issue right here. A low alpha-beta ratio means those healthy tissues are exquisitely sensitive to the size of the daily fraction.
So if you hit them with a massive daily dose, their repair mechanisms are completely overwhelmed.
Yes, and you cause severe, permanent, late toxicity. Fibrosis, bleeding, strictures.
And that biological reality is the entire historical rationale for what we call conventional fractionation in radiation oncology.
Right. For decades, we gave small, tiny daily fractions, usually 1.82 grays a day for 7 or 8 weeks.
Those small daily doses allow the low alpha-beta healthy tissues, like the rectum, time to repair their sublethal beta damage overnight.
Meanwhile, we steadily chip away at the high alpha-beta tumor, which is dividing too erratically to repair itself effectively.
That was the golden rule of radiation. Small daily doses protect normal tissue. But prostate adenocarcinoma breaks that paradigm entirely, doesn't it?
It shatters it. Multiple clinical modeling studies over the past 3 decades have estimated that the alpha-beta ratio of prostate cancer is astonishingly low.
It is not 8 or 10.
No. It is estimated at approximately 1.5 gray.
1.5 gray. I mean, that number completely flips the script. That is actually lower than the surrounding late-reacting normal healthy tissues.
Yes. The rectum has an estimated alpha beta of approximately 3 gray.
And the bladder is generally considered to be around 3 to 5 gray.
So the implication of that math is what drove a total revolution in how we treat this disease. If the prostate tumor's alpha-beta ratio is 1.5 and the rectum is 3.
It means the prostate cancer cells are actually more sensitive to larger daily fractions than the healthy normal tissues surrounding them.
Exactly. Let's go back to that boxing analogy from the beginning, because this is where the abstract physics meets the real world.
Right, so our prostate tumor is that strange boxer with a glass jaw for heavy punches.
Because its alpha beta is so low, it has very poor ability to handle large, overwhelming doses of radiation in a single sitting.
If you hit it with a big, heavy swing, like a large daily fraction, it goes down fast. But ironically, because it grows so slowly, it can absorb 1,000,000 tiny, quick, conventional jabs without taking critical damage.
It just repairs and ignores the small doses.
And how would you describe the healthy organs in this scenario?
The healthy organs, the rectum and the bladder, are like a tough, weathered, veteran heavyweight fighter.
Because their alpha beta is around 3 or 4, they can actually take a single heavy punch relatively well. They have robust repair mechanisms for moderate damage.
But what destroys a veteran fighter is a long, drawn-out, agonizing fight of 1,000 tiny jabs over 8 long weeks. They wear down.
The tissue gets inflamed, scarred, and eventually fails. So because of this unique 1.5 versus 3 gray ratio, if we throw a heavier, larger daily punch, it preferentially knocks out the prostate tumor before it destroys the surrounding tough tissue.
Functionally, what we are doing by increasing the dose per fraction is improving the therapeutic ratio.
We're widening the gap between the probability of tumor control and the probability of normal tissue complications.
Exactly. This is the absolute biologic foundation for moderate hypofractionation, which uses 2.4 to 3 gray per fraction.
And even ultra-hypofractionation, or SBRT, which pushes all the way to 6 to 8 gray per fraction.
Right.
Now, I hear that, and the math sounds incredibly elegant. But I have to challenge this a bit.
Please do.
Isn't this alpha beta of 1.5 just a mathematical guess? I mean, we can't exactly stick a probe into our 66-year-old patient's prostate and measure his personal alpha-beta ratio in real time on the table.
You are absolutely right to be skeptical, and this is a common point of contention in the radiobiology community.
Right, because the 1.5 gray number is not a physical law of the universe measured in a vacuum.
No, it is derived from retrospective mathematical modeling of massive clinical outcomes data sets.
So researchers looked at thousands of patients treated with different fraction sizes, plotted their biochemical failure rates, and back-calculated the curve to find the alpha-beta that best explained the outcomes.
Which means it's an aggregate average, not an individual guarantee. And biology is incredibly messy.
Extremely messy. The alpha-beta framework is a highly simplified model of a wildly complex tumor microenvironment.
It assumes a static state. It doesn't fully account for the 4 R's of radiobiology.
Right, like reoxygenation. It doesn't account for the reoxygenation of the hypoxic, oxygen-starved center of the tumor over time.
Or the repopulation of tumor cells between treatments. And crucially, it doesn't account for the distinct intrinsic radiosensitivity of different Gleason patterns.
Oh, that makes sense. The rapidly dividing cells of a Gleason pattern 5 might not have the exact same 1.5 alpha-beta ratio as the indolent, slow-growing cells of a Gleason pattern 3.
Exactly. So a patient with a highly aggressive, poorly differentiated tumor might actually have a slightly higher alpha-beta ratio than the mathematical model suggests.
But despite those caveats and the messiness of human biology, this 1.5 framework has proven to be incredibly robust.
It really has. It predicted that fewer, larger fractions would work safely before the massive randomized phase 3 trials actually proved it in human beings.
It serves as our guiding principle. It gives us the confidence to change our treatment paradigms.
But before we explore the modern era of larger fractions, we have to look back at the absolute total dose.
Right, because before we realized we could change the size of the punch, the oncology community's first instinct was simply to throw more of the conventional punches.
What happens when we just crank up the total conventional dose to the absolute limit?
Which brings us to the era of dose escalation. The clinical evidence that, historically speaking, more is more.
The dose escalation story in prostate cancer is foundational. It is built on a bedrock of multiple, large, randomized phase 3 trials conducted in the late 1990s and early 2000s.
And what is most remarkable about this era of research is the consistency, right?
Yes. Across almost every major trial, we saw a reproducible finding, an absolute 15 to 20% improvement in biochemical progression-free survival, or BPFS, when we utilized higher total doses.
Just to put numbers to that for you, the listener, the historical standard was around 68 to 70 gray.
And dose escalation meant pushing that total dose up into the 76 to 80 gray range, still using those tiny 2 gray daily fractions.
So we're talking about going from roughly 35 daily visits up to 40 or even 44 daily visits to the radiation clinic.
Correct. But while that biochemical control, meaning keeping the PSA blood test undetectable, improved consistently and beautifully, the estimates for harder, more definitive clinical endpoints were historically very elusive.
Endpoints like distant metastasis-free survival, prostate cancer-specific mortality, and overall survival were imprecise.
Many early critics argued we were just treating a blood test number, not actually saving lives.
Let's dive into the specifics of the two massive anchor trials that define this era, because they are required knowledge for any practitioner.
First up is the MD Anderson Cancer Center trial, the MDACC trial, led by Pollack and Kuban.
This trial is legendary, not just for its design, but for its incredibly dogged, long-term follow-up.
It really set a benchmark. The MDACC trial randomized 301 men with clinical T1 to T3 disease.
And they confirmed no nodal involvement.
Right. It was a broad mix of risk groups, roughly 20% low risk, 46% intermediate risk, 34% high risk.
And what were the exact interventions they compared?
They compared the historical standard of 70 gray against an escalated dose of 78 gray. All treatments were delivered in conventional fractionation.
Crucially, for our understanding of pure radiation physics, no androgen deprivation therapy, or ADT, was allowed in this trial.
None. So it was a pure, unadulterated test of radiation dose against the tumor. No hormone blockers muddying the water.
How did the patients fare at the 10-year mark?
At 10 years, the dose escalation clearly improved freedom from biochemical and clinical failure. The success rate was 73% in the high-dose, 78 gray arm, compared to only 50% in the standard 70 gray arm.
And importantly, that significant benefit appeared across all the risk groups, from low to high.
Yes. A 23% absolute improvement is massive.
If I tell a patient I can increase their chance of a cure by 23% just by adding a week and a half of treatments, they take that deal every time.
Every time.
But the reason this trial is legendary isn't the 10-year data. It's the 20-year follow-up data. We rarely get 20 years of clean follow-up in modern oncology.
We don't. The 20-year data publication is an absolute treasure trove. It proved that the biochemical control durability persisted over decades.
Wow.
At 20 years, the freedom from biochemical failure was 93% for the 78 gray arm versus 88% for the standard arm.
Wait, I want to clarify something there. Earlier you said at 10 years it was 73% versus 50%.
Right.
But at 20 years, it's 93 versus 88. That seems like the gap narrowed and the numbers went up.
I need to be precise with the endpoints there. The 10-year numbers, the 73% versus 50%, represented the overall freedom from biochemical or clinical failure for the entire cohort.
Okay.
The 20-year numbers I just cited, the 93 versus 88%, specifically represented the durability of control for patients who had not yet failed by a certain time point, or specific subgroup analyses.
Yep.
Let me recenter the most critical finding of the 20-year data. It is where we finally started seeing the harder survival endpoints budge.
Right, because for years the critics said, you are just suppressing PSA. You aren't preventing metastatic spread. Did the 20-year data silence them?
Suggestively, yes. At 20 years, the MDACC data showed a numerically lower rate of distant metastasis. It was only 1% in the high-dose arm compared to 4% in the lower-dose arm.
Even more strikingly, they saw a numerical reduction in prostate cancer-specific mortality. 5% in the high-dose arm versus 10% in the standard arm.
Functionally, that means double the number of men died directly from their prostate cancer if they received the lower dose of radiation.
But I know you are going to urge caution with these specific numbers.
I have to. We must analyze this in the broader statistical context. This was a single institution trial. By the time you reach 20 years of follow-up, the absolute number of living patients and the absolute number of events, meaning deaths or metastases, is relatively small.
So, statistically speaking, it is suggestive evidence, not ironclad, definitive proof that dose escalation universally saves lives across the board.
But clinically, It strongly implies that hitting the tumor harder with 78 gray confers profound benefits far beyond just keeping the PSA blood test low. It prevents the tumor from escaping the pelvis.
Okay, so that is the single institution data. It's powerful, but usually we want to see that replicated on a national scale. Let's look at the Cooperative Group Confirmation Trial, RTOG 0126.
A massive, complex undertaking by the Radiation Therapy Oncology Group. RTOG 0126 randomized 748 men.
This cohort was generally focused on favorable intermediate risk disease. Think of patients with T1b to T2b disease, mostly Gleason 6 with a slightly elevated PSA, or Gleason 7 with a lower PSA.
And their randomization was incredibly precise. 70.2 gray versus 79.2 gray.
And again, just like MDACC, no ADT was used.
Right, pure radiation dose comparison. At 10 years, the results beautifully mirrored the MD Anderson data.
Dose escalation improved biochemical control. 78% versus 61%.
It also reduced the rate of distant metastasis, 4% in the high-dose arm versus 7% in the standard arm.
And when they followed these men out to 15 years, that distant metastasis benefit held up strongly. 6% versus 11%.
So high dose clearly stops the cancer from spreading to the bones.
But, and this is the frustrating reality of prostate cancer research, there was no overall survival benefit. Overall survival was hovering around 67% in both arms at 10 years and remained statistically identical at 15 years.
Which tells us a profound truth about competing mortalities. Many of these men are dying of other causes long before the prostate cancer can claim them. Cardiovascular disease, secondary malignancies, strokes.
Prostate cancer is inherently slow-growing, and these men are entering trials in their late 60s and 70s.
Right. Improving their prostate cancer control doesn't make them immortal. They still succumb to the natural aging process.
But beyond the survival data, RTOG 0126 gave the oncology community something else that totally changed modern radiation practice.
Yes. It wasn't just about the total dose. It was a profound lesson about the delivery method of that dose.
This is perhaps the most clinically relevant legacy of the trial.
Definitely. When RTOG 0126 originally launched, it required participating clinics to use a technique called 3D conformal radiation therapy, or 3D CRT.
Let's explain 3D CRT physically. It's a massive leap forward from the old 2D X-rays because we finally add CT scans to build a 3D model of the patient.
But the radiation beams were still relatively basic. We would shape the beam to match the outline of the prostate, usually shooting from 4 to 6 different angles.
The problem was the beam had a uniform intensity. It was like throwing a bucket of paint at a stencil.
The prostate got covered, but the high-dose paint splashed heavily onto the rectum sitting directly behind it, and the bladder sitting directly above it.
And the toxicity data using 3D CRT to deliver 79.2 gray was rough. Patients were suffering significant rectal bleeding and urinary pain.
But mid-trial, the investigators amended the protocol to allow a brand new technology, intensity-modulated radiation therapy, or IMRT.
This is where the physics gets beautiful. With IMRT, we aren't just throwing a bucket of paint. We have a machine with a collimator made of dozens of tiny individual metal leaves.
Those leaves slide in and out of the beam path dynamically while the machine is on.
It allows us to essentially paint the radiation dose with a tiny, precise brush. We can blast the prostate with high-intensity radiation and then slide a metal leaf over to cast a literal, physical shadow over the anterior wall of the rectum,
dropping the dose to the healthy tissue drastically, and thank goodness they amended the trial to allow it.
On retrospective analysis, the patients in the trial who received IMRT had significantly reduced acute grade 2 plus gastrointestinal and genitourinary toxicities during their treatment.
Furthermore, there was a strong statistical trend toward decreased late grade 2 plus GI toxicity.
Let's ground grade 2 GI toxicity for you, the listener, because it sounds sterile. What does that actually mean for the patient sitting in front of us?
Grade 2 GI toxicity means a tangible alteration in their daily quality of life. It means they are experiencing moderate rectal bleeding that might require iron supplements or minor medical intervention.
It means chronic diarrhea requiring daily medications like loperamide. It means fecal urgency, the feeling that they need to find a bathroom immediately, which can cause massive anxiety when leaving the house.
It is not life-threatening, but it is life-altering.
So IMRT proved absolutely vital. It was the technological bridge that allowed us to safely deliver these massive curative 79.2 gray doses while curving the radiation away from the rectum to prevent that life-altering diarrhea and bleeding.
And out of that toxicity analysis, RTOG-0126 identified a very specific quantitative benchmark that we still use in clinics today. The planners found that if the volume of the rectum receiving 70 gray, a metric we call the rectal V70, was at or above 15%, the patient had a significantly unacceptably higher risk of developing that grade 2 plus rectal toxicity.
That is the functional trade-off trap right there. Higher dose equals higher cure rate, but higher late GI toxicity if you aren't meticulous.
You cure the cancer, but you leave the patient tied to a bathroom for the rest of their life.
Which is why toxicity mitigation is the primary focus of modern treatment planning. Today, we rely heavily on strict adherence to those dose volume constraints, utilizing highly conformal IMRT, and increasingly the use of rectal spacers.
I want to touch on rectal spacers briefly because they are such an elegant mechanical solution to a complex physical problem.
When a patient comes in, we essentially perform a minor outpatient procedure where we inject a liquid hydrogel into the microscopic space between the back of the prostate and the front of the rectum.
Within seconds, that liquid cross-links and solidifies into a soft gel pad, physically pushing the anterior rectal wall about a centimeter or more away from the prostate.
In the world of radiation physics, 1 centimeter is a massive canyon. Thanks to the inverse square law, that physical distance allows the high-dose radiation beam to drop off precipitously before it hits the rectal tissue.
And the gel naturally dissolves and is absorbed by the body about 6 months later, long after the radiation is finished.
Okay, so the MDACC and RTOG trials established the historical baseline. 76 to 80 gray is the standard for conventional treatment. But we have to talk about the recent curveball that was thrown into the oncology community.
Oh, yes.
Because I was sitting in the audience at the ASCO Genitourinary Cancer Symposium in 2024 when they presented the GETUG-18 data, and it caused an audible murmur in the room.
It definitely challenged the prevailing narrative. The GETUG-18 trial, conducted by the French Cooperative Group, randomized 505 men.
But unlike the previous trials that focused on intermediate risk, this trial explicitly targeted high-risk prostate cancer patients.
Right. These are men with a PSA over 20, a highly aggressive Gleason 8 or higher, or bulky T3 to T4 disease growing outside the prostate.
And they randomized them to the classic 70 gray versus 80 gray. But here is the massive kicker that sets this trial apart. Both arms received 3 full years of androgen deprivation therapy, or ADT.
Which is incredibly important for clinical relevance. Unlike the older trials, this design actually reflects modern clinical reality.
We never, ever treat high-risk disease with radiation alone anymore. We always use long-term hormone suppression to starve the microscopic disease systemically.
So the burning question was, if you are already chemically castrating the patient and starving the tumor for 3 years with ADT, does the local radiation dose still matter? Do we still need to push to 80 gray, or is 70 gray enough when paired with heavy hormones?
What were the long-term results?
The results reported at ASCO GU 2024 were striking. They showed a 10-year overall survival of 77% in the 80 gray arm versus 66% in the 70 gray arm.
Wow.
Furthermore, cancer-specific survival was 96% versus 90%, and progression-free survival was 84% versus 72%. Every single metric strongly favored the 80 gray dose-escalated arm.
An 11% absolute improvement in overall survival. That is almost unheard of in localized prostate cancer trials.
It is huge.
If I'm thinking about this functionally, it means that even when the systemic therapy is working overtime, you still have to decisively crush the primary tumor locally to prevent it from mutating and seeding lethal metastases years later.
That is the biological implication. However, as an analytical practitioner, I must temper your excitement just a bit.
Ooh, always a catch.
These are incredibly striking results, yes. But they were reported at the meeting level as an abstract presentation. We are still awaiting the mature, peer-reviewed manuscript to scrutinize the statistical methodology, the subgroup analyses, and the toxicity data.
That's a fair point. We have to see the final published data before we declare it absolute gospel. But if the peer review confirms those numbers, it would be the first randomized dose escalation trial in history to show a clear, undeniable overall survival benefit.
Correct. And it firmly answers a very modern clinical question. Dose still matters profoundly, even when you have heavy systemic therapy on board. The synergistic effect of heavy local ablation and systemic suppression appears to be the key to long-term survival in high-risk disease.
So, to summarize the historical evolution for you, the listener, if you are treating conventionally at 2 grays a day, 76 to 80 gray works beautifully to control the disease, but it requires meticulous IMRT planning and strict dose constraints to protect the rectum.
That is the foundational truth of modern external beam therapy.
But wait, this brings up a massive contradiction. Okay, let's hear it. If total dose matters so much, and 80 gray is proven to be incredibly effective, why on earth is the modern oncology community rushing to do fewer treatments with lower total doses? If 79.2 gray was the holy grail of the R2G era, why are we suddenly stopping at 60 gray?
This is where we bring everything full circle back to that radiobiological foundation. We return to the alpha-beta ratio of 1.5 gray.
Ah, okay.
Moderate hypofractionation is not about giving less effective dose. It is the direct translation of that unique prostate biology into a highly efficient clinical standard.
So we are giving a lower total physical dose, say 60 gray instead of 80 gray, but we are delivering it in far fewer fractions, making each individual daily fraction physically much larger.
Exactly. So instead of 2 grays a day for 40 days, we were giving 3 grays a day for 20 days.
And because the prostate tumor has that strange glass jaw for heavy punches, biologically the tumor feels the exact same, if not greater, lethal impact from those larger 3 gray fractions as it did from the 80 gray of tiny jabs.
Meanwhile, the healthy rectal tissue, which can handle larger fractions moderately well, is spared the long, drawn-out inflammatory trauma of 40 daily treatments.
And practically, this is a massive win for the patient. Going to a cancer center every single day for 8 weeks is exhausting.
It disrupts work, requires daily transportation, and is psychologically draining. Cutting that down to 4 weeks is a huge quality of life improvement.
There are 2 main regimens that have emerged as the absolute evidence-backed champions of this approach. 60 gray in 20 fractions, which is 3 gray per fraction, and 70 gray in 28 fractions, which is 2.5 gray per fraction.
Let's break down the massive phase 3 trials that proved this paradigm shift was safe and effective. To keep them organized, I like to categorize the major moderate hypofractionation trials into 3 distinct buckets: the good, the clean, and the toxic.
I love that framework. Let's start with the good. The massive United Kingdom anchoring trial, known universally as the CHIT trial.
The CHIP trial was a logistical triumph. They randomized over 3,200 men. The cohort was predominantly intermediate risk.
And they designed 3 arms to truly test the boundaries of hypofractionation.
Arm 1 was the conventional standard at the time: 74 gray in 37 fractions. Arm 2 was 60 gray in 20 fractions. And Arm 3 pushed it even further, dropping the dose to 57 gray in just 19 fractions.
And what was the ultimate verdict on disease control?
The trial successfully proved that 60 gray in 20 fractions was statistically non-inferior to 74 gray in 37 fractions. It worked just as well for long-term cancer control, with 5-year biochemical failure rates virtually identical between the 2 arms.
However, the third arm, the 57 gray in 19 fractions, failed to meet the non-inferiority threshold.
That is a critical lesson. Examinees and clinicians pay very close attention to that lower bound. You cannot just infinitely drop the total dose, even if you are using larger fractions.
57 grays simply did not provide enough biological damage to reliably eradicate the tumor. 60 gray is the established sweet spot.
What's equally fascinating is the toxicity profile that emerged from CHIP. Acute gastrointestinal toxicity, meaning the bowel issues the patient experiences during the actual weeks of treatment, was higher with the hypofractionated arms, 38% versus 25%.
The larger daily punches did cause more acute inflammation.
But crucially, the late toxicities, the chronic permanent issues that persist for years after treatment, were ultimately similar between the standard arm and the 60 gray arm.
The acute inflammation settles down, and the long-term tissue function is preserved. Okay, that's the good. Now for the trial you called the clean, the PROPHET trial, conducted in Canada. Why does every genitourinary radiation oncologist universally praise the design of this specific trial?
Because the methodology was absolutely pristine, and it eliminated the major confounding variables that plagued other studies. PROPHET randomized 1,206 intermediate-risk men. Crucially, absolutely no ADT was used in this trial.
It was a pure test of radiation efficacy. But the main reason it is beloved is the control arm. They compared the 60 gray in 20 fractions against a properly dose-escalated conventional control arm.
Right. Because a common trick in clinical research is to compare your brand new experimental treatment against an old, outdated, low-dose treatment. If you do that, your new treatment might look artificially superior.
But Profit didn't take the easy way out. They compared 60 in 20 against a robust high-dose 78 gray in 39 fractions.
Exactly. It was a true heavyweight bout, and Profit proved definitive non-inferiority for biochemical progression-free survival against that highest standard of care. Both arms achieved 5-year control rates hovering right around 85%.
And even more importantly for patient counseling, there was absolutely no significant increase in late grade 3 or higher GI or GU toxicity.
Grade 3 implies toxicity requiring surgical intervention or blood transfusions. It was clean, undeniable evidence that 60 gray in 20 fractions is biologically and clinically equivalent to 78 gray conventionally.
So Profit and CHEP deeply solidify the 60 and 20 schedule. But what about the other major schedule, the 70 gray in 28 fractions?
That evidence comes primarily from the United States Cooperative Group, RTOG 0415. This trial focused exclusively on low-risk men. It compared 73.8 gray in 41 fractions against 70 gray in 28 fractions.
Did it meet the non-inferiority threshold for curing the cancer?
It did. The cancer control was excellent. But I always highlight a critical caveat with this trial when discussing it with residents. There was a modest but statistically significant bump in late grade 2 GI and GU toxicity in the hypofractionated arm.
Right.
The hazard ratios were 1.6 for GI toxicity and 1.3 for GU toxicity compared to the conventional arm. The severe late grade 3 toxicities were similar, but that grade 2 bump is a real phenomenon.
Which means, practically speaking, more patients in that arm ended up having mild to moderate chronic diarrhea or persistent urinary urgency years later. It's not life-threatening toxicity, but it definitively affects their daily quality of life.
Which is why, while 70 and 28 is recognized as a perfectly valid, guideline-supported standard of care, many modern clinics lean heavily toward the 60 and 20 schedule from Profit and CHP.
The toxicity profile for the 3 gray fraction just appears slightly more favorable and cleaner in the long-term data.
Right.
Okay, so we've covered the good and the clean. Now let me play devil's advocate for a moment. If I'm an ambitious young doctor looking at this data, I might think, well, if larger fractions are biologically superior and more convenient, why stop at 3 grays a day? If the math works, why not do 4 grays a day? Or 5 gray, let's cure this guy in a week and a half. Is it impossible to mess up hypofractionation?
That ambition takes us directly into the territory of the toxic and the danger zone. The Dutch HYPRO trial is the ultimate cautionary tale for radiation oncologists who think they can outsmart biology.
Tell me exactly what happened in HYPRO.
HYPRO randomized intermediate to high-risk men to standard 78 gray conventionally versus an experimental hypofractionated arm of 64.6 gray delivered in just 19 fractions.
Wait, 64.6 divided by 19, that is roughly 3.4 gray per fraction. That is a significantly hotter daily dose than the 3 grays used in Profit.
It was incredibly hot, and the trial was actually designed as a superiority trial. They didn't just want to prove it was equal, they hypothesized that this hotter, heavier dose would be vastly superior for cancer control.
And did it work?
It failed entirely. There was absolutely no difference in relapse-free survival between the arms. But the toxicity story was highly unfavorable, even alarming. They saw significantly more acute GI toxicity and a marked increase in late grade 3 plus GU toxicity, 19% in the hypofractionated arm versus 13% in the standard arm.
A 19% rate of severe urinary toxicity, meaning strictures requiring dilation, severe bleeding, or surgical intervention. That is unacceptable. Why did it fail so disastrously on toxicity compared to Profit, just by adding 0.4 gray to the daily fraction?
It all comes down to a fundamental radiobiological calculation called the BED, or biologically effective dose. The BED is a mathematical formula that takes the total physical dose and the size of the daily fraction, applies the alpha-beta ratio, and spits out a number that represents the true absolute biological damage inflicted on the tissue.
Okay.
Dr. David Brenner and Dr. Eric Hall, two of the foremost leaders in radiobiology, analyzed these trials and noted a very clear, unforgiving threshold.
What is the threshold?
If your moderate hypofractionation regimen pushes the tumor, BED, assuming a tumor alpha-beta of 1.5 above a value of 183, or if you push the late normal tissue, BED, assuming a healthy tissue alpha-beta of 3 above 136, you cross a biological red line.
The normal tissue repair mechanisms completely collapse, and you get unacceptable, severe toxicity.
Yes. And the HYPRO trial blew right past those safe thresholds.
It absolutely shattered them. The tumor BED for the HYPRO regimen was well over 210. It was just too hot. The biological punch was too heavy.
We saw a very similar painful lesson in the MD Anderson-Hoffman trial, right? They tested 72 gray in 30 fractions, which is 2.4 grays a day, against 75.6 conventionally.
Yes. That trial actually did show superior cancer outcomes for the hypofractionated arm, but the late GI toxicity spiked unacceptably, jumping from 5% in the conventional arm to 12.6% in the experimental arm.
But the MD Anderson team is brilliant, and they actually figured out the mechanical solution to fix that toxicity during the trial, didn't they?
They did. They went back to the IMRT planning computers. They found that if they tightly and aggressively constrained the dose specifically to the rectum, mandating that the rectal volume receiving 65 gray had to be kept strictly below 15%, that severe toxicity rate dropped all the way back down to 8%.
Which proves a massive clinical point. As we increase the dose per fraction to leverage the alpha-beta ratio, our contouring of the anatomy on the CT scan and our IMRT dose volume constraints have to be flawless.
With conventional 2 gray fractions, the tissue is forgiving. If you slip up slightly, the rectum repairs it. With 3 grays or 3.4 gray fractions, there is zero margin for error. The radiation planner has to be a perfectionist.
Absolutely. And before we leave the topic of hypofractionation, I want to add one critical clinical pearl regarding patient selection. Because not every man is a perfect candidate for these larger fractions, we have to discuss the Fox-Chase trial caveat.
Oh, this is a vital nuance for daily practice.
The Fox-Chase trial compared 76 gray conventionally against 70.2 gray in 26 fractions. Overall, the cancer outcomes and the major toxicities were similar between the arms. But the investigators did a deep dive into patient subgroups and found a specific cohort of men who suffered disproportionately.
Who was it?
Patients who came into the clinic before treatment with significantly bad baseline urinary function had markedly worse late GU toxicity if they received the hypofractionated regimen.
Right, and we quantify baseline urinary function using the IPSS, the International Prostate Symptom Score. It asks patients about how often they pee at night, if they have to strain, if their stream is weak.
So in the trial, men who had an IPSS score over 12, meaning moderate to severe baseline symptoms, fared poorly with the bigger daily doses.
If a guy is already getting up 4 times a night to pee and has a weak stop-and-start stream because his prostate is enlarged and squeezing his urethra, we need to be incredibly careful.
Exactly.
Do we just tell him, sorry, you were disqualified from the 4-week treatment, you have to come in for 8 weeks?
Not necessarily. The consensus guidelines from ASTRO actually state that age, baseline comorbidities, and baseline urinary function should not automatically exclude a patient from being offered moderate hyperfractionation.
Do you still offer it as an option?
You do, but you change the conversation. You counsel them heavily and transparently. You tell them, because of your current urinary symptoms, if we use the shorter, heavier treatment schedule, your prostate is going to swell more acutely, and you are at a statistically higher risk for long-term chronic urinary side effects compared to a man with perfect flow. It becomes an exercise in true shared decision-making.
Okay, let's bring all this radiobiology and trial data back to our specific case anchor. Our 66-year-old man sitting in the room. He has that 2.1 centimeter PIR8S 5 lesion, clearly visible on his MRI, sitting right there in his right peripheral zone.
Right.
We've firmly established that 60 gray in 20 fractions is a fantastic evidence-backed plan for him. But here's my fundamental question. Are we really just going to treat his entire prostate gland as one homogeneous block of tissue to 60 grays and completely ignore the fact that we can literally see the exact location of the aggressive tumor on his MRI? Why aren't we targeting that specific spot with more dose?
That question is the exact leading edge of modern genitourinary radiation oncology. It is the perfect entry into the FLAME concept.
FLAME, it sounds intense and ablative.
It is. It stands for Focal Lesion Ablative Microboost in Prostate Cancer. This phase 3 trial, published by Kirkmeijer in the Journal of Clinical Oncology in 2021, fundamentally changed how radiation oncologists interact with prostate MRI imaging.
Because historically, for decades, radiation oncologists just treated the whole prostate as one uniform black box block of tissue. We
Right.
knew the cancer was in there somewhere based on the blind needle biopsies, but we couldn't see it on a standard CT scan.
So we just blasted the entire gland with 78 gray and hoped we hit the worst of it. But with the advent of modern multiparametric MRI, the fog lifted. We can now see exactly where the dominant intraprostatic lesion, the DIL, is sitting. We can see its borders.
Exactly. So the investigators of the FLAME trial hypothesized a new paradigm. What if we treat the whole prostate gland to a standard, safe, conventional dose, but simultaneously use our IMRT machines to blast that specific visible MRI lesion with a massive targeted focal boost?
They tested this rigorously. They randomized 571 men. It's important to note the risk profile here. Most of these men, 84%, were high risk, and 65% of them were actively on ADT during the radiation.
The control arm received the absolute standard of care at the time. 77 gray and 35 fractions to the whole prostate gland. That's a classic, safe 2.2 gray per fraction dose-escalated regimen.
But the experimental arm got that exact same 77 gray to the whole prostate background, PLUS, a simultaneous integrated boost, or SIB. While the background prostate was getting 2.2 grays a day, the MRI-defined dominant lesion was simultaneously being pushed up to a staggering total dose of 95 gray.
95 gray. In the context of the trials we just discussed, that is an absolutely enormous amount of radiation to drop inside a human pelvis.
It really is.
And what were the results of dropping that massive dose directly onto the tumor?
The results were nothing short of incredible. The focal boost arm drastically improved the 5-year biochemical disease-free survival. It went from an already respectable 85% in the standard arm all the way up to 92% in the boost arm. The hazard ratio was 0.48 for disease-free survival.
Let's translate that hazard ratio. That means they cut the risk of the patient suffering a biochemical failure, the cancer coming back by more than half, simply by adding that focal boost to the visible lesion. That is a massive clinical victory.
Huge.
But my immediate reaction is terror regarding the toxicity. At what cost do we achieve that? You cannot just drop a 95 gray nuclear bomb inside the prostate and not burn the urethra running through the middle of it or the rectum sitting directly behind it to an absolute crisp.
That was the primary fear of every safety monitoring board looking at this protocol. But this is where the toxicity data is so surprising and so crucial to understand. The severe toxicity was virtually identical between the two arms.
Really?
Yes. Late grade 2 plus GU toxicity was 28% in the boost arm versus 23% without it, a slight numerical bump, but statistically insignificant. And late GI toxicity was basically perfectly matched, 13% versus 12%.
How is that physically possible? How do you increase the dose to a staggering 95 gray on a target inside the prostate and not increase the severe damage to the surrounding organs?
Because of the absolute, unyielding golden rule of the FLAME trial protocol. And this is, without a doubt, the most important takeaway for anyone listening who actually plans these treatments.
Let's play this out so the listener truly understands the mechanism. Let me play the role of an ambitious, slightly overconfident resident in the clinic. I just read the FLAME paper. I see the incredible 92% control rate. I say, this is amazing. 95 gray to the tumor cures them. I'm going to pull up the MRI. I'm going to draw a tight circle around the tumor with my mouse, type 95 gray into the treatment planning software, and hit deliver.
And if you do that in a real clinic, the attending physician will halt you immediately, pull you away from the computer, and say, absolutely not. You are going to severely injure this patient.
Why? The phase 3 trial clearly says 95 gray.
Because you ignored the foundational rule. The rule of the FLAME trial was that the organs at risk constraints, the OAR constraints for the rectum and the urethra, were completely non-negotiable. They were the supreme law of the treatment plan. If pushing the dose to 95 gray on that lesion resulted in even a fraction too much dose spilling over and hitting the urethra or the anterior rectal wall, the dosimetrists were legally forced by the protocol to back off the boost dose.
Ah, I see. Constraints first, boost second. It is a hierarchy of priorities.
Exactly right. You only escalate the dose where the physical anatomy makes it safe to do so. In the actual execution of the trial, many patients in the experimental arm never actually reached the full 95 gray.
That makes a lot of sense.
If a patient's tumor was sitting right on the posterior edge of the prostate, jammed against the rectum, or if it was wrapping centrally right around the urethra, the planners couldn't safely push it to 95. The trial protocol strictly mandated keeping the most exposed portion of the urethral D 0.1 cc below 80 gray. It also mandated keeping the bladder D 2 cc below 80 gray.
Think of it like a controlled demolition of a building in a crowded city. You can use high-yield explosives to completely vaporize the target building, which is the tumor, but only if the blast radius doesn't shatter the glass of the hospital next door, the urethra.
That is a perfect physical analogy.
If the tumor is too close to the hospital, you have to use less explosive power. You accept a slightly less definitive demolition to guarantee you don't destroy the critical infrastructure.
And a secondary, detailed safety analysis of the trial by Groyan and colleagues confirmed exactly why this rule is vital. They found that if the urethral dose is allowed to creep up even slightly, the incidence of severe GU toxicity, pain, bleeding, strictures creeps up right along with it in a linear fashion without any safe threshold.
So the entire philosophy of FLAME is fundamentally different from the traditional whole gland dose escalation of the early 2000s.
Yeah.
You are no longer just turning up the dial on the whole machine. You're escalating the dose only exactly where the tumor is, and only when the specific spatial anatomy of that individual patient allows it. If the anatomy puts the urethra at high risk, you simply accept a lower boost dose. Maybe the dosimetrist can only safely hit 85 gray or 88 gray. You accept that because you never ever violate the OAR constraints.
It is the ultimate expression of personalized adaptive dosimetry. And it sets the stage beautifully for the next generation of clinical trials, which are currently exploring whether an EBRT focal boost, like we saw in FLAME, is better, worse, or equal to using a physical radioactive brachytherapy seed implant to deliver that massive boost, or using SBRT to deliver it in 5 days. It is a profoundly exciting time for prostate mapping and targeting.
Okay, we have covered an immense amount of theoretical and historical ground. We went through the linear quadratic radiobiology, conventional dose escalation from MDACC to GE-TUG18, the moderate hypofractionation safety data from PROPHET and HYPRO, and the focal boosting philosophy of FLAME.
It's a lot.
It is time to synthesize this. Let's put all these puzzle pieces together and actually write a prescription to treat our 66-year-old patient.
Let's systematically walk through the clinical decision-making algorithm, the if-then ladder, for this specific presentation.
Step 1 is always establishing the risk group. We analyze his biopsy and blood work, and we firmly established he is an unfavorable intermediate risk patient based on his T2B palpable nodule, his PSA of 14, and his Gleason 4+3 pathology.
Step 2 is deciding the fractionation schedule. What is our primary baseline approach for the whole gland?
We look to the major society guidelines. Based on the joint 2018 ASCO, ASTRO, and AUA consensus guidelines, moderate hypofractionation is fully strongly supported as a standard of care.
And because our patient is intermediate risk, his disease profile perfectly matches the inclusion criteria for the Canadian PROPHET trial.
Therefore, the primary attending recommendation for the base radiation plan is 60 gray delivered in 20 fractions, 3 gray per day, Monday through Friday, for 4 weeks. It is highly effective for cancer control. It is vastly more convenient for the patient's life than an 8-week conventional course, and as PROPHET showed, it has a proven, highly clean toxicity profile.
But then we move to step 3, the boost. Do we employ the FLAME concept on him to try and push that cure rate even higher?
To answer that, we must look very closely at his MRI anatomy. The initial prompt stated he has a 2.1 centimeter PI adjus 5 lesion located specifically in the right peripheral zone of the prostate.
The location in the peripheral zone is the key anatomical factor here. The peripheral zone sits at the back and the outer edges of the prostate gland. It is generally located quite far away from the urethra, which runs right down the middle through the central transition zone.
Exactly. Because his specific dominant lesion is in the peripheral zone, safely distanced from the delicate urethra, we will absolutely attempt to design a FLAME-style simultaneous integrated boost.
We will instruct the dosimetrist to scale the daily dose up specifically to that MRI-defined DIL, aiming for a biological equivalent of up to 95 gray.
But UT, and there's a big but here.
But only if the rectal constraints hold. This is the catch. While the peripheral zone is far from the urethra, It sits directly adjacent to the anterior wall of the rectum.
So this is exactly where we deploy that rectal spacer hydrogel we discussed earlier. We will inject that gel to physically push his rectum a centimeter away from the peripheral zone.
If the spacer deploys beautifully and creates a wide gap, the dosimetrist might be able to paint the full 95 gray onto the tumor without spilling dangerous dose onto the rectum. If the patient's anatomy is tight and the rectum is still too close despite the gel, we legally scale the boost back. The rule remains, constraints first, boost second.
That covers the local therapy. Step 4 is systemic therapy. Because he is categorized as unfavorable intermediate risk, he absolutely requires concurrent short-course androgen deprivation therapy.
We generally prescribe 4 to 6 months of testosterone suppression to weaken the cancer cells systemically while the radiation destroys them locally. We aren't going to dive into the deep pharmacological details of ADT today. That is a massive topic reserved entirely for episode sets of this series, but it is a mandatory, non-negotiable part of his overall curative prescription.
So, if we read the final treatment plan back to the patient, he will receive 60 grays in 20 fractions to the whole prostate gland, an integrated focal boost heavily targeting the MRI lesion up to 95 gray if the rectal constraints allow, all supported by a temporary 4 to 6 month course of ADT. It is an elegant, highly customized, perfectly evidence-based plan.
Before we move on to board review, I know there's one point of clinical nuance you wanted to discuss, an area where there is still genuine heated debate among experts, an area of true clinical equipoise.
Yes, I think it's important to acknowledge where the map is still being drawn. What if we changed the patient scenario slightly? What if our patient wasn't intermediate risk? What if he walked in as a very high-risk patient with a Gleason 9 tumor, a PSA of 40, and bulky disease that requires 2 to 3 full years of systemic ADT? This brings us right back to the GETUG18 question from the ASCO meeting.
Exactly. This is the debate you will hear in the hallways of every major cancer center. Some doctors look at the CHIP trial data, which did include a small, roughly 12% subgroup of high-risk men, and they feel completely comfortable and justified treating even the highest-risk disease with the shorter 60 gray and 20 fraction schedule.
But other doctors, perhaps the more conservative practitioners, look at that newly reported GETUG18 data, the trial that showed a massive 11% overall survival benefit for high-risk men receiving long-term ADT when they were treated with the traditional heavy 80 gray conventional regimen. Right. And because we do not currently have a massive dedicated phase 3 trial directly comparing 60 grays in 20 fractions against 80 grays conventionally, specifically in a cohort of purely high-risk men on long-term ADT, many experienced practitioners still heavily prefer the conventional 78 to 80 gray regimen for those absolute highest-risk cases. They want to deliver the maximum absolute biological dose proven to extend overall survival, even if it takes 8 weeks.
It is a perfect example of the art of medicine meeting the science of medicine. We have the data, but we have to interpret it based on the individual patient's risk tolerance and disease severity.
All right, we have synthesized the clinical flow perfectly. But let's pivot to the final major segment. Let's focus on board review, pearls, and traps. Because understanding the grand philosophy of oncology is wonderful, but passing your high-stakes oral boards requires recognizing and avoiding very specific, fatal pitfalls in your answers.
I have watched many residents fail the prostate cancer case for very predictable, avoidable reasons. Let's aggressively highlight the 3 major oral board traps. What specifically fails an examinee when they are presented with a localized prostate case?
Trap number 1.
Prescribing a non-dose escalated conventional regimen without providing a very specific, compelling anatomical justification to the examiner.
Meaning, the resident gets the case, looks at the examiner, and confidently says, I will treat this intermediate risk patient to 70 gray in 75 fractions.
That is an immediate glaring red flag. If you say that in an exam room today, you are signaling to the examiner that you haven't kept up with the last 20 years of published literature. Multiple randomized trials, MDA, CC, RTOG, the MRC trial, all definitively prove that dose escalation to the 76 to 80 gray range improves biochemical control by 15 to 20%. If you choose to use conventional 2 gray daily fractions, your final dose must be in that 76 to 80 gray range to pass, period.
Trap number 2.
Saying hypofractionation is hypofractionation
Uh-huh.
and treating all the various trial regimens as if they are completely identical.
Oh, this is a fatal flaw of laziness.
It truly is. If the examiner asks you for your specific dose and you casually wave your hand and say, "I'll just hypofractionate him," the examiner will immediately dig in and expose you. You cannot mathematically or biologically equate the safe 60 gray in 20 fractions regimen from CHIP and Profit with the highly toxic 64.6 gray in 19 fractions regimen from HYPRO. One is a safe established standard of care, the other is dangerously hot and cause unacceptable severe urinary damage. You must specify the exact total dose, the exact number of fractions, and you must know which specific phase 3 trial supports that choice.
Trap number 3.
We just spent a long time discussing the mechanism of this one. Boosting the MRI lesion without explicitly stating out loud that the organs at risk constraints take priority.
If you swagger into the exam room, look at the MRI, and say, "I see a PI RAD-S5 lesion," I will aggressively blast it to 95 gray using a simultaneous integrated boost. And then you stop talking, you will fail the safety check.
Because you demonstrated a lack of respect for normal tissue biology. Always, always append that boost statement with this exact phrasing. Provided that the urethral and rectal dose constraints can be strictly met by the dosimetrist. If the constraints cannot be met due to anatomy, I will reduce the boost dose to prioritize the safety of the organs at risk.
Excellent. That will save careers. Now, before we hit the rapid-fire questions, let's give you, the listener, a quick, memorable tool to lock in the endpoints of all those massive dose escalation trials we discussed.
The alphabet soup of trials can be overwhelming. How do you suggest keeping the outcomes organized?
Think of the historical evidence as climbing a ladder, where the endpoints get harder and harder to prove as you climb higher.
I like that.
Rung 1, the base. All dose escalation trials showed BPFS benefit. Biochemical control, lowering the PSA, was universally achieved whether you look at American or European trials.
Right.
Rung 2, moving up, MDACC and RTOG0126 showed DM benefit at long follow-up. Distant metastasis only drops if you have the patience to follow them in for 15 to 20 years.
And the final rung.
Rung 3, the top. GETUG18 reported OS benefit with ADT awaiting full publication. Overall survival is the hardest endpoint to hit, and so far, we only see it when we combine high dose with long-term systemic therapy.
All trials for biochemical control. The big 2 long-term trials for distant metastasis. The newest French trial for overall survival. It is a clean, structural way to organize a massive amount of historical data in your head under pressure.
All right, time for the board blitz. These are rapid-fire multiple-choice questions. I am going to ask you, listening to this right now, whether you're driving, at the gym, or staring at a textbook, try to answer the question in your head before the expert breaks down the underlying logic. Ready?
Let's test the knowledge.
Question 1. A 64-year-old man with intermediate-risk prostate cancer is planned for definitive EBRT. The plan is to use radiation alone, without any ADT. Which of the following clinical endpoints has been most consistently, universally improved by dose escalation across AOL randomized prostate EBRT trials? A. Overall survival. B. Biochemical progression-free survival. C. Prostate cancer-specific mortality. D. Distant metastasis-free survival.
The best, most historically accurate answer is B, biochemical progression-free survival. As we just outlined in the memory ladder, every major trial of the era, MDACC, RTOG0126, MRCRT01, the Dutch trial, they all unequivocally demonstrated improved BPFS. The harder, more definitive endpoints like overall survival or distant metastasis-free survival were either statistically imprecise, only seen after decades of follow-up, or were not uniform across the board due to patients dying of cardiovascular disease or old age.
Perfect. Question 2. Test the hypofractionation data. A radiation oncologist plans to treat an intermediate-risk prostate cancer patient with moderate hypofractionation to spare the patient an 8-week treatment course. Which of the following regimens has the strongest, cleanest non-inferiority data against a properly dose-escalated conventional control arm with no increase in late toxicity? A. 70 gray and 28 fractions from RTOG0415. B. 60 gray and 20 fractions from the Profit trial. C. 64.6 gray and 19 fractions from the HYPR trial. D. 72 gray and 30 fractions from the MDACC Hoffman trial.
The absolutely best answer is B, 60 gray in 20 fractions from the Canadian Profit trial. If we evaluate the methodology, Profit is the cleanest trial design. It successfully proved statistical non-inferiority for biochemical control against a high-dose control arm of 78 gray, and critically, it achieved that with absolutely no increase in late severe toxicity. If we look at the distractors, RTOG 0415, the 70 and 28, is valid but had a modest grade 2 toxicity bump. HYPRO 64.6 in 19 failed its superiority endpoint and was dangerously toxic to the urinary tract. MDA-CC Hoffman showed better cancer control but initially worse GI toxicity until they fixed the rectal constraints. Profit is the unimpeachable gold standard for non-inferiority.
Last one, question 3. This tests the flame philosophy. A patient with a PI-RADS5 dominant intraprostatic lesion is found to have the tumor sitting immediately adjacent to the urethra on MRI. He's being planned for definitive EBRT with a flame-style focal boost. The dosimetrist successfully achieves the background dose of 77 gray to the whole prostate gland, but realizes they can only deliver 82 gray to the DIL before the strict urethral radiation constraint is completely maxed out. What is the most appropriate, safe clinical action? A. Accept the 82 gray to the DIL and proceed with the plan because OAR constraints always take priority. B. Force a DIL dose up to 95 gray regardless of the urethral dose because the Phase 3 trial mandates it for cure. C. Reduce the whole gland background dose down to 70 gray to create the mathematical room for the 95 gray boost. D. Abandon the EBRT focal boost entirely and send the patient for surgery.
The safest, most appropriate answer is A. Accept the 82 gray to the DIL and proceed with treatment. This question is the ultimate conceptual test of the flame safety philosophy. Boost ambition must never, ever override normal tissue safety. Delivering 82 gray to the visible tumor is still a highly meaningful, localized dose escalation over the standard 77 gray background dose. By accepting 82 gray, you never violate the urethral constraint, ensuring the patient won't suffer a stricture. You never inappropriately underdose the whole gland background just to make room on the screen for a boost. And you certainly don't have to abandon a perfectly good radiation plan just because the anatomy prevents you from hitting the maximum theoretical 95 gray. Safety first, escalation second.
We have covered an incredibly dense amount of theoretical physics, radiobiology, and clinical application today.
We truly have. If I had to distill this entire complex discussion down to a single guiding principle that we want everyone to remember when they walk into the clinic tomorrow, it is this. The unique biology of prostate cancer allows for highly efficient treatment. That low alpha-beta ratio of 1.5 gray is the biological engine driving modern patient-friendly therapy. 60 gray delivered in 20 large fractions is the absolute workhorse regimen for the vast majority of your localized patients.
It is efficient, it is safe, and it works. But we must never forget the lessons of the past. Total dose still heavily matters for cure. Escalate the dose appropriately, utilize a modern focal boost to the MRI lesion if the physical anatomy safely allows it, but protect the rectum and the urethra at all costs with meticulous constraints and hydrogel spacers.
When you apply the physics correctly, the fog of treatment planning truly begins to clear.
It really does. At the start of this discussion, we talked about how navigating prostate radiation decisions feels like steering a massive ship through dense fog, trying to read murky diagnostic landscapes and competing maps from different decades. But the massive, rigorously conducted trials we just dissected together, MDAC, RTOG, Profit, Flame, they are the lighthouses. They cut through the fog. They show us exactly where the safe harbors of high cure rates are and exactly where the hidden reefs of severe toxicity lie waiting.
The route to curing the patient is actually quite clear, provided you deeply understand the fundamental radiobiology guiding the ship.
In our next exploration, we are going to expand the radiation toolkit even further. We've talked about moderate hypofractionation today, but we are going to look at what happens when we push that alpha-beta physics to the absolute extreme. We will be covering prostate SBRT, treating the entire gland in just 5 days, the intense, localized physics of high-dose rate and low-dose rate brachytherapy seed implants, and how a clinician actually chooses between all these incredible modalities.
It's going to be fascinating.
But until we dive into that, I want to leave you with one final, slightly provocative thought to mull over regarding the future of our field. If a low alpha-beta ratio already allows us to cure prostate cancer safely in just 5 heavy fractions of SBRT, and we know from basic biology that deep tumor hypoxia makes the core of the cancer highly resistant to radiation. Radiation? What happens when we start combining those massive ablative SBRT fractions with novel next-generation radiosensitizing drugs designed specifically to target tumor metabolism and reverse that hypoxia in real time? Could we eventually cure high-risk prostate cancer in a single day? That is where the next decade of laboratory and clinical research is aggressively heading, and the possibilities are going to be wild.
It is a profound frontier. I look forward to unpacking that biology with you.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode.
Thanks for tuning in.